going through the nursing process. Okay, so in this example, remember the assessment phase is always first. It's always the most important, and it includes everything, right? So not just your hands-on assessment and vitals, but your head-to-toe assessment, and then any subjective data that your patient gives you. And then when you're in clinical, you're also looking at labs, looking at their history, all of that, any diagnostic testing that they have. Okay, so assessment phase is first, and it's collecting data, right? Okay, so for this scenario, we have some subjective data. The patient tells you that they haven't gone to the bathroom since before their surgery. They're feeling bloated, they're feeling a little nauseated. Some objective data, so your hands-on stuff, when you go to inspect their abdomen, it looks distended. You listen to your bowel sounds next, and then you're gonna palpate, so it would feel distended, which means like firm, like hard. Okay, so we could have a patient with a round abdomen, but it should be nice and soft, okay? But distended means that it's firm or hard, and that's usually painful for that patient. Okay, and then bowel sounds are hypoactive, which means they're happening less frequently than they should. They're voiding only small amounts, which voiding is urinating, so just urinating small amounts. That urine that we're looking at is dark and it's concentrated. Their intake is less than their output. They're on opioids, which are our narcotic, our pain medications, and they're having decreased mobility because they had hip surgery, and so that's why they're on the narcotics, okay? So then based on this information, we can identify several nursing diagnoses that go with that. The first one is constipation. Okay, so constipation is the problem. That's one of those funny ones that it's all three. It's a nursing diagnosis, it's a sign or symptom, it's also a medical diagnosis. It's one of those wonky ones. Okay, but we would identify that the problem is constipation, and then the related to is always the second part, that's the cause. Okay, so why does this patient have constipation? It's related to the opioid use and the decreased mobility. Okay, and then your third part, the reason that when we do those activities, you're supposed to list out all the abnormal data is because that's your as evidenced by. That's what leads you to identify this problem. Okay, so they have no bowel movement for 3 days and they're having abdominal distension. Okay, so that's the data that you would collect. Okay, so then when you're working on interventions, it's going to revolve around the cause, and then when you're reassessing to see if they're improving, the as evidenced by is what you're going to focus on to see if they're improving. Okay, the second problem that we can identify is impaired urinary elimination. Okay, so just a general statement that we know normal urinary elimination and this is not it. Okay, so it's impaired. Related to what's the cause for this specific patient, they're having some post-op retention, so they had surgery. So as you read about, surgery and anesthesia and lots of different medications can lead to constipation and impaired urinary output as well. Okay, also that limited mobility. Okay, and then how do we know? What's the evidence that tells us, that led us to identify this problem? Is they're having a decreased urinary output, and when they do have output, it's concentrated. Okay, so instead of being good amount, more than 30 mLs per hour, right, and being like a clear pale yellow, it's dark and concentrated. Okay, and then the third one, because of these problems that are going on, they're also at a risk. So it's not an actual problem. They don't have a UTI right now, but if we don't, kind of resolve and focus on these things, they could develop a urinary tract infection. So there's no as evidenced by for a risk for nursing diagnosis because it's not occurring, but we know the cause of why they have a risk is because they're having urinary stasis, which just is another term for saying they're not emptying their bladder like they should, and the concentrated urine. Okay, so if the urine is concentrated, it's more irritating to the GI system, so can lead to infections. And then again, if we don't release our bladder when our bladder is full, the urine is just kind of sitting in there, and then we can grow bacteria and have infection. Okay, so those are our nursing diagnosis or our problems that we can come up with and identify for this patient. So some goals then for this patient, some example, patient will pass a soft form stool within 24 to 48 hours, right? So they're having constipation. What's normal GI elimination, that's what we want for this patient. Okay, they're not urinating enough, so another goal would be urine output greater than or equal to that 30 per hour, and it should be light yellow in color within 12 hours, which is the time that you can put on there. Okay, so Okay, some longer term goals, maybe the patient will verbalize understanding of strategies to maintain regular bowel and bladder elimination before discharge. All right, and then implementation, so our nursing interventions, okay? So it's not just medications, we're gonna use words like assess and monitor and educate, encourage. All of those are all nursing interventions, okay? So even if it's not something that we specifically would do, remember we're the managers of care, we plan the care for the patient, so we identify all the possible nursing interventions. Okay, so for that constipation, a main easy fix is to increase our fluid intake. So either if they can take it orally, or depending on what's going on, maybe now we're looking at IV fluids. Okay, but we want it to be, remember we said about 2 liters for fluid intake, so we want to increase that unless it's contraindicated. So unless your patient has like heart failure, right, is our main example, where we kind of have to watch their fluid intake because the heart just can't manage it. Okay, so unless contraindicated. Increasing dietary fiber, so we talked about how that's a subcategory of our carbohydrates. It helps create bulk, it gives our GI system a little workout, and it helps us eliminate like we should. Okay, and there's some examples of our main high fiber foods, our fruits and our vegetables. Remember, fresh is always best, then frozen and then canned, right? Because the further you get into preserving and saving the food, the less nutrients are saved, the more sodium is added to maintain and keep that food preserved. Okay, so fruits, vegetables, and then the whole grains, like our chickpeas, beans, legumes, whole grain breads, things like that. Okay, another easy one that's often overlooked is just get them up walking. So all of our patients, unless contraindicated, even same day of surgery, we're getting patients up and we're getting them moving because we know about these complications that can occur. Okay, so encourage ambulation, whether it's you, nursing assistant, a physical therapy assistant, whoever it is, we know that it has to be done, so it would be part of our care plan. Okay, administer a stool softener, our main one, and one of the ones that is everybody okay? That we're gonna do a drug sheet on today is Docusset sodium or Colace. So you've probably seen it in your nursing home patients, you've probably seen it in the hospital already. It's a very commonly prescribed medication. It looks like a little orange jelly bean, it's like a gel cap, okay? And depending on where you look, sometimes it's categorized as a laxative, but it's really just more of a stool softener. So when you give your patient Colace, it's not gonna make them go, it just makes it easier to go, okay? So it's just part of like a daily, it's not a PRN, here, take this and it'll work. It's an everyday preventative type thing, and all the other things also have to be in place. So the fluid, the fiber, the ambulation, all of that. Okay, so Docusset sodium or Colace is a stool softener. Okay, and then just providing privacy, establishing a toileting routine, so that'll help your patient go. Some people, have a difficult time going in public, so just giving them privacy, and then a toileting routine. So it's, if you leave them in bed all day, it's gonna be more difficult for them to feel the urge to go. Even if they don't feel like they have to go, once you're doing your rounding, get them up, move them a little bit, take them to the bathroom, and then maybe they'll have a bowel movement. But you don't know if you don't try, so at least every 2 hours or so, getting them up and taking them to the bathroom. All right, for that impaired urinary elimination, say a lot of the same stuff, okay? So make sure we get them up if we can. If they can't get out of bed, we have to use the bedpan, okay? But we wanna manipulate their bed and put them in a sitting position as much as we can, just to help gravity do its thing and their organs to sense that they're in the right position to eliminate. But if we can, we wanna get them up, bedside commode or up to the toilet, up to the bathroom. Okay, monitoring their intake and output, just to make sure that we have an awareness of if they're eliminating or not. Again, encouraging those oral fluids. Water is always good, and then cranberry is healthy for the GI system, the urinary system, so it kind of keeps your system in the correct pH balance and kind of prevents irritation. So that could help. Assessing for bladder distension. So remember back from head to toe, we talked about that, and I said go home and feel your bladder, it's above your pubic bone. You normally shouldn't feel anything, but then next time you really, really have to pee, before you go to the bathroom, stop, lay down, and feel and see if you can feel anything, okay? It's kind of a tricky assessment skill to learn. Depending on the size of our patient, it's not always as easy to do. So we have our bladder scanner. Has anybody got to see a bladder scanner in the clinical setting yet? They're real common because our patients have these problems. They're very common. So usually every unit has one, and it's just a handheld ultrasound machine. So you'll put that ultrasound gel over the patient's bladder, hold it, position it correctly, and it gives you an image and tells you how much urine is still in the bladder. Okay, so we could bladder scan. Okay, and then just communicating, notifying our provider, keeping them aware of any issues if they are having the low output and the dark concentrated urine. All right, and then moving into the risk for the UTI. So again, it's going to be a lot of education. So still some patients don't know that we need to wipe front to back for our female patients front to back because there's bacteria in the back that's normal to be there, but if it moves to the front, it's abnormal and can cause an infection. We had mentioned that E. coli is the most common bacteria that's grown when your patient has a UTI, and it's usually from improper hygiene, or we'll have patients who are like low income, who are incontinent, and they want to preserve their pads as much as possible. So just educating them, like once they're dirty, you need to change them, get something new, and clean that out. Okay. Also, the fluids is going to help for that. The cranberry, encourage voiding again, just because with the stasis, if the urine is just sitting, there's a chance for bacteria to grow. So we want to get them up and have them go to the bathroom. And then avoid unnecessary catheterization. So I think next week or so, you guys are going to start looking at catheters in lab. So we only use it if the pros outweigh the cons or if the benefits outweigh the risks, because there is such a high risk of infection from putting that in. It is a sterile procedure, so we need to make sure we're sterile when we do that. So if we contaminate anywhere along that, the steps of inserting it, now we're the ones who are maybe causing infection. Like if we go to put that catheter in and we brush the catheter up against something and then don't go get a new catheter, carry on and put it in the patient, we could cause infection from inserting it and then after they have it. So if you're a nursing assistant, you've probably done catheter care, so you know it has to be done at least once a shift, usually more often. So again, if that doesn't get done, now there's bacteria growing on that tube, so they can have infection. Okay, so when your patient does have a Foley, your chart, maybe you've already seen this. If your patient had a Foley and you logged in, you maybe had a notification pop up that said your patient has a Foley. Do you still want them to have it? Because the system knows that it's a risk for infection, so every day it needs to be assessed, and the nurse will have to put in documentation why they still need it. Okay, so that's what that is speaking to there. All right, and then the evaluation phase. So if they met all their goals, then everything we planned would have come true for them. So they passed a medium soft stool on day 3. Their urine output improved now to 40 per hour. It's pale yellow, there's no odor, and they're verbalizing the importance of all of that education that we gave them. All right, any questions on this activity? All right, this one is okay. All right, so we've got 4 patients here, each with 4 different problems, all of which you've read about for your Take It to class here. Okay, so this first one, we've got a patient, no bowel movement in 5 days, abdominal discomfort, taking opioids post-surgery, hypoactive bowel sounds. Okay, so all that sounds familiar from the ADPI example we just went through. So Kennedy, what did you identify as the problem?
Constipation.
Yeah, constipation is the problem. Okay, that's right. And then Gabby, what are some interventions you came up with?
We said encourage fluids, increase fiber, and encourage foods that are rich in fiber. Possible stool softeners or enema, and then encourage just like walking and movement.
Yep, perfect. Okay, nailed it. Okay, so increase fluids. If they can take them orally, we'll do that route. Maybe they need some IV, just depends on what's going on with them. Get them up walking. Give them some high fiber foods, like Gabby said, fruits, vegetables, whole grains. Okay, and then medications, maybe we would start with like the most gentlest, so it's gonna be that Colace, that stool softener. Ideally, your patients, once they're scheduled for surgery, and especially once opioids or narcotics are on board, they should already be ordered some stool softeners daily to just prevent that problem. But if they're not already, we would start that. And then if that doesn't work, we'd go up with the stronger meds, laxative, or maybe enema. Okay, so she covered it all, so that was great. All right, patient B, then, okay, we've got opposite problem, right? 6 loose stools per day. Their potassium now is lowered. It's 3.0, which, does anybody remember the normal range for potassium? Yeah, 3.5 to 5.1, so we're low there. Weakness and fatigue. They ate some spicy food yesterday. They've got some dry mucous membranes. Okay. So what's the main problem? Who wants to tell me? For this one, Caitlin?
Diarrhea.
Yeah, diarrhea is the main problem. Okay, so the opposite of our patient B. Okay, so that's the main problem. That's the main thing we're seeing. But what's a complication that's occurring because of the diarrhea? And this is something that we talked about last week on Wednesday.
Dehydration.
Dehydration, a little bit, but specifically, yep.
Hypokalemia.
Yeah, hypokalemia is exactly what we're looking for. So the complication, the main problem is diarrhea. And again, we're not just like, oh, they have diarrhea, no big deal. No, because we know that it can throw off their fluid and electrolyte balance. There is some dehydration stuff probably going on with the dry mucous membranes. But the priority complication is that hypokalemia. Remember, the potassium is one of our major, most important electrolytes. It controls heart function. We worry about arrhythmias with this patient. They would have to be put on a heart monitor. Okay, so what are some interventions for this patient who thinks they got it? Sophia?
Rehydrate.
Yeah, first off the bat, you need to rehydrate.
Increase the potassium intake.
Yeah, after that, once we've got some fluids going, we also need some potassium replacement. With them being this low, we're probably looking at some IV potassium versus oral potassium. Sorry, keep going.
And then monitor electrolytes.
Yeah, monitor electrolytes, make sure that it doesn't happen again. Anything else?
We said maybe a stool culture which proceeded and possibly.
Okay, yep, so she's talking about now maybe a stool culture to see like what's going on. Maybe there's infection. Spicy food is like one of those risk factors for diarrhea. So it could just be from that, but we don't know. So once they are having lots of loose liquid stools, they will order us to test those. C. diff we're usually worried about. Could be some parasite infection, who knows what it could be. So some more testing, and then exactly depending on what's going on, maybe we're looking at giving an anti-diarrheal now. And then patient C, we've got sudden severe abdominal pain. They're vomiting. They've got that distended abdomen, no bowel sounds. Last VM was a couple of days ago. Just some extra info in there that they are getting their water in. Okay, so what's this problem that we're having with this patient? Thinks they got it. Grace? Yeah, it's an obstruction. Okay, so they have a bowel obstruction of some type. So when they have a bowel obstruction, what's the intervention that we do for that? Mark?
I put NG2.
Yeah, NG tube. Okay, so we talked a little bit about it. You won't hands-on put an NG tube down until next semester, but it's our main intervention. So bowel rest, so they would be put NPO, right, because they're already full. If we keep adding to it, they could burst and then they could become septic, because all that stuff that it's okay contained in your GI system, but if it gets in your abdominal cavity, that's no good. So we put them NPO, and we put the NG tube in there, and we kind of just monitor, okay? They probably need some IV fluids if they're not getting anything orally. Okay, so that's an obstruction. They need an NG tube, and they need to be NPO. Then our last one that we'll go through before break here, they have black tarry stool. Stool again is just GI elimination. Black tarry stool, their fatigue, some background info, they're taking ibuprofen daily, which was one of your med sheets. We had a question on that on our last exam. and then their heart rate is 110, okay, so they're a bit tachycardic. Okay, so what's our main problem for this patient? Who thinks they got it? McKinley? Yeah, it's probably a GI bleed of some type, okay? And yet she specifically said upper. Usually when we see the black tarry stool, that means that your body has been like processing and digesting that blood. Or if it's bright red stool, then it's usually gonna be a lower GI bleed. Okay, but GI bleed is good, so that black tarry stool is another way of saying melena is black tarry stool. Okay, so they're having a bleed. So what are we gonna do for this patient? Anybody have any ideas?
We said stop insects, labs, and take vitals.
Okay, so stop the NSAIDs because we know now that that can cause GI bleeding. What is one of your tests that you read about that identifies, because it's black and tarry, but like if you take an iron supplement every day, maybe you'll have black tarry stool. So what's that test that you read about that identifies blood in the stool? Yeah, fecal occult stool. So occult means hidden. So it's just a little handheld like pH paper, and you just open it up, you get a sample of the stool from 2 different areas, put it on 2 different areas of that pH paper, and then now that's it. We close it up and we send it to the lab. We used to develop them right there at the bedside, then we turn it over, open up the other side, drop the developer on it, and we can tell right there if there's blood in that stool or not. Somewhere along the way, I'm sure it has to do with money, we don't do it anymore, so we send it to the lab and we have to wait. So they will process it and then they'll tell us. Okay, so first we start with the least invasive, so we do that fecal occult stool. Yeah.
Put the seed into the valve.
Get a stool sample.
For the seed into the valve because sometimes like you know,
Yeah.
like that's
Yeah.
kind of why like we put that in.
Yeah, so we do the fecal occult stool. If it's positive, then we go to look at maybe scope of some type so they can get in there and see what's going on. So our previous patient that had the diarrhea, we worry about it progressing to a bleed. Okay, so diarrhea is bad in itself because it causes the fluid electrolyte imbalance. But if they keep having the diarrhea, there's irritation, there's inflammation in here. So we're worried about it eventually turning into a bleed situation. And then if they keep having bleed situations, we're worried about cancer. Because if you have abnormal growth there, every time you have inflammation and irritation, every time the bowel tries to heal, it's growing new tissue. So if that happens over and over and over again with like our Crohn's patients, our irritable bowel patients, all of that, they can be at a higher risk for developing cancer because of that new regrowth that constantly has to be occurring, so they can regrow abnormal themselves. Okay, depending on what's going on, we're also looking at, Carolyn said labs, we're talking about like the red blood cell count, the H&H, because if those are dropping now, if they're losing enough, now maybe this patient also needs a blood transfusion. Okay, all right, so what did you think? What order did you guys put them in? It's kind of tricky, but who do you see first, or what's the highest priority, most risk of complications here? What do you guys think? Okay. So your priority is going to be your bowel obstruction. Okay, that's the main one. Like I said, if we don't resolve it, that their bowel could bust. Okay, and then they could bleed out, and they can become septic, all of that. Okay, so bowel obstruction is going to be first. After that is your melena patient, your black tarry stool patient. After that is your patient with the low potassium. Okay, and then the last one is your patient with constipation. All right, we'll go ahead and take a break, and then we'll continue. Yeah, again, I wish I could clone myself. I wish I could do all the clinicals.
You should.
I really wish. All right, what's going on with this urine? So this first patient that we had here with some of this data, we've got a 68-year-old male, 6 hours post-op hip surgery, has not voided, okay, so they're not peeing, bladder stand, and there is 650 mLs in there, so it's not like there's nothing in there, it's just not coming out. Some vitals for you, again, without knowing their trends, we don't know. I mean, they're a little bit elevated, but who knows? For this patient, IV fluids are running. So again, we've got intake, so we should have output. And then they're complaining of lower abdominal discomfort. Okay, add all these things together, and what is your patient's problem? Who thinks they got it? Sophia?
Urinary retention?
Yeah, this is urinary retention is the name of that problem. Okay, so they're just retaining. And then based on the data, what's the cause for this patient, Addie?
Post-op surgery?
Okay, yeah, so anesthesia. Okay, so this patient had surgery, they had anesthesia. Anesthesia causes urinary retention, right? It puts all your muscles and everything to sleep, so it takes a while to wake them up. So this is a common complication after surgery, one that we're on the lookout for. Okay, so that's the problem, that's the cause. What is the priority action? What do you guys think? What'd you come up with, Jace?
Encourage them to try using condoms first, and if not, contact the provider, you might get a straight path.
Perfect, beautiful. Okay, so yeah, get them up, try to get them up and encourage them to go to the bathroom, run the water, all those things. But if not, we put in a catheter, a specific type of catheter, right? We're not gonna put in a Foley catheter, which is a double lumen. We're not gonna put in a 3-way catheter, which is for continuous bladder irrigation. We're just gonna use a straight catheter, okay? Because we know it's a matter of time and movement that this problem should resolve. Okay, so it's still sterile, we still do all the stuff, but it's just a straight cap. We drain the bladder into a collection device, we get rid of it, and then again, we get them up, moving, we hope that they can eventually use the bathroom. Okay, so this is just a straight cap situation. Okay, and because we know that it's a common complication, usually that's built into your orders. Like you would have protocol if the patient does a void, bladder scan, if they have such and such, go ahead and straight cap. So a lot of times, depending on where you work, we can even skip that step. It's built into our protocol. All right, great. What about number 2 here? What's the problem? You've got a 24-year-old patient. They've got burning with urination and frequency. So these are things that your patient is not often going to tell you and don't just come about in a head to toe. You have to ask. You have to specifically put the vocabulary out there and say, you know, are you having any burning? Are you having frequency? Which means that you always feel like you have to go. Like you just went, it's not like you're taking in copious amounts of water, but you constantly feel like you have to go. And it's because of irritation, or another problem that we're gonna talk about with older men is BPH, benign prostatic hypertrophy. So in men, the prostate gland surrounds the urethra, which is where urine exits the bladder. Benign prostatic hypertrophy means it's not cancerous, but the prostate cells are enlarging, they're growing. Okay, it's a common problem with older adults. So as it enlarges, it constricts the urethra, so they can't empty their bladder frequently. So they'll have frequency, they'll also have something called hesitation, where they go and it takes them a while to start going, and they have dribbling where they go a little bit. Okay, so all those are related to the BPH. Okay, but this one is a female, she's got burning frequency. We did a UA, which is a urinalysis, okay, and that just shows like what's in there. And then if leukocytes, what type of blood cell are leukocytes? Are white blood cells. So if we do a UA, which is a common test, if there's leukocytes, which are white blood cells, then we would flip it and do a urine culture, which is not a common test. Okay, so a culture is done, and then that grows the specific bacteria. It's a culture and susceptibility or sensitivity. So it tells us what bacteria is in there. It tells us what antibiotic that is susceptible to or will kill it. Okay, so the UA shows that there's white blood cells. Temp is 100.4, which is on the elevated side. They're drinking water, but only 1 cup a day, which is way less than what they're supposed to have. And then also they're running a lot. Okay, so their intake and output is going to be off here. Okay, so based on this data, what is the problem for this patient? Somebody new want to tell me?
A UTI.
Yeah, this patient has a UTI, urinary tract infection is what they have. So based on what's going on, what's some simple teaching that we can give just based on the data that we have? Anybody want to tell me? Megan?
Increase water.
Yeah, increase your water intake, like your balance is way off. 3 miles daily is like a whole lot, so what's going on there? If you're training for a marathon maybe, but like if not, that's a lot. And definitely intake and output have to match here. Okay, so so that's gonna be the priority teaching. And then those other things that we talked about, wiping front to back. We haven't talked about it, but like wearing cotton underwear versus nylon underwear, loose clothing versus like tight restrictive clothing. Doing showers instead of baths. If you do take a bath, not doing like a bubble bath or having harsh soaps in there, all of those things can help. If they're sexually active, making sure that they drink water around that time and that they void and urinate after sexual activity to kind of clear out and clean out the urethra. Okay, and then what's the expected treatment? Kind of hinted at it all along. So for this patient, what's the expected treatment that we're gonna expect to be ordered? Gabby? Yeah, antibiotic of some type, okay, whichever one is specific based on that culture and sensitivity that we do. Okay, wonderful. All right, patient C, we're gonna find out what do the labs indicate and then what's the nursing action here. So we've got a BUN of 32, which is above our high end of 20. Okay, we've got a creatinine of 1.8, which is a little bit above our 1.1, 1.2 is the high end there. We've got dry mucous membranes. We've got a slightly low blood pressure. We've got urine that's dark and concentrated. So now, what is the problem that these labs indicate? Who wants to tell me? Gabby?
Dehydrated or?
Yeah, they're dehydrated, dehydration, or decreased renal function, kidney function. Okay, but there's dehydration going on here. Okay, so was dehydration being the problem? What's the priority nursing action for this patient?
Encourage oral fluid.
Yeah, encourage fluids, either oral or IV, depending on what's going on with the patient. Okay, labs show dehydration, assessment data shows dehydration, so we need to rehydrate. All right, and then our last patient here, we've got a 52-year-old female, leaks urine when coughing or laughing. So there's different types of incontinence that you've read about. This is one of the most common types. There's no urgency. This history does show 3 vaginal births and a UA is normal. Okay, so we're not looking at infection or anything. So what type of incontinence would this be? Anybody figure it out?
Urinary with a weak, due to a weak pelvic floor.
Yeah, that's the cause of it. What's the name of it? Casey. Yeah, stress incontinence. So whenever there is stress, so from laughing or like jumping on a trampoline, whenever there is stress on the pelvic floor muscles, we leak. Okay, so that is the cause, that's the type. So what would the intervention be for this? Mark, do you want to? Yeah, PFMTs, pelvic floor muscle training. Okay, so they have weak pelvic floor muscles. Okay, the vaginal births are related to that because when you have a vaginal birth, everything gets stretched out and loosened up. You kind of tear apart those muscles a little bit. So part of your part of teaching should be PFMTs. Okay, what are PFMTs or pelvic floor muscle training? It's exercises to strengthen those muscles. So if you're peeing and you stop the flow of your pee, if you hold it, you're exercising your pelvic floor muscles. Okay, so all that is you would tell your patient, go ahead and make that motion. We can all do it right now. We can squeeze those muscles, and that's pelvic floor muscle training. Okay, one of the last times I taught this, my phone heard, and my phone thought that I needed it, and so I had all this advertising for there's electronic devices now that you can put something up in there, and you can squeeze against it, and you can hook it up to your phone, like you could have play a little video game with it, where your guy is running, and every time you squeeze, it jumps over the thing. So there's all kinds of stuff now available for you. So your phone might have that for you now. Okay, but we can just have them squeeze those muscles if they don't want to buy any extra equipment for that.
I heard that if you do that too much, like if you avoid yourself from peeing too much, that can actually cause you to be able to not hold your pee.
You can make your pelvic floor muscles too
Like,
strong.
or the thing is like, or it's like something that truckers, I don't know, they hold the pee for too long or for years and years, and their muscles that hold that get weak and they have issues holding the pee.
Yeah, that was in the.
I'll have to check that out. She said, yeah, that was in the room. I'll have to check it out. All right, 2 more activities to go here. And then we have a Kahoot. Okay, so these ones, just like last week, these last 2 are case studies. So you have some information, and then these are just multiple choice questions. Can I stop this? Okay. All right, so we've got a patient, 72, their diagnosis is benign prostatic hyperplasia. Okay, so they have that enlargement of the prostate tissue, so it's gonna constrict on the urethra and they're gonna have all those signs and symptoms that we talked about. Their chief complaint is difficulty urinating. Okay, so it comes to the emergency department, I feel like I have to go to the bathroom, but I can't get anything out. So that's that like frequency and hesitancy feeling. He reports increased difficulty starting his urine, hesitancy. This morning he felt severe lower abdominal discomfort and was only able to pass a few drops of urine. Okay, so just like a small bowel obstruction, when they're retaining, we worry now about their organs literally busting, which can cause hemorrhage, death, sepsis, all of those complications. Okay, so we do an assessment, we palpate their bladder, we do note that it's distended and tender on palpation. They're having pressure and discomfort, unable to void. We've got some vital signs. BP and pulse are a little bit elevated. Again, we don't know their norms, so we're not sure, but we know they're a little bit normal if he's just kind of sitting there resting, a little bit abnormal. And his urinary output in the last 8 hours is only 50 ml. So we want at the very least 30 per hour. Okay, so that's way too low. So we suspect urinary retention, and the cause of that is BPH. Okay, so some little information there. It's caused by an obstruction such as an enlarged prostate. Could also be like a stone somewhere in the urinary drainage system that's preventing urine from being released. Medications like our anesthesia or different medications that you'll get more into further in the program, or nerve problems. Sometimes if they have nerve damage, they can't feel the sensation and then they don't have control of the muscles to be able to void. Okay, so our role is to assess, monitor, assist with voiding, and then maintain comfort and safety. Okay, so which assessment finding is most consistent then out of these with urinary retention? Who wants to tell me? Yeah, that's B. I heard someone say they're like all B, except for the last one. So B, frequent small voids and a distended bladder. Okay, so they're not going enough, or they're having to go often, and when they go, it's just a little bit, and they have that distension. Okay, what's the priority nursing action then? Who wants to tell me? Elizabeth? Yeah, B again. Yeah, B again. So we're gonna do our assessment. Okay, we're gonna let the provider know what we find. Okay, and then number 3, we have an order then for an intermittent or straight cath for this patient. What's the main goal of straight cathing somebody, Abby? Is B again, so to drain that retained urine and then to relieve the discomfort, okay, because it's very uncomfortable when you have a full bladder. Okay, and then after catheterization, Mr. Jones reports dizziness. What should we do for this? B. It's B again. So we want to get a set of vital signs because they're dizzy. So we're worried now, you know, are they tachycardic? Are they hypotensive? We want to get all that information because if we just call the provider and say they're dizzy, they're going to ask us, well, what are their current vital signs? Okay, so we want to get a set and notify the provider. And that's just kind of to let you know that if we do like drain a large amount, they can have a drop in blood pressure, right? Because your blood pressure is your fluid volume. So if we drain a ton, we could see them get dizzy and we could see them get hypotensive. Just depends on a lot of other factors as well, but that is something that you might see. All right, and then what teaching point does this patient know or does this patient need because of their history of the BPH and the urinary retention? B again, okay, drink plenty of fluids, avoid holding urine for long periods. Okay, and then that one C, it says use decongestants. Decongestants are one of the drugs on that list that can cause retention, just because of the way that it works in the body, so we would not want them to use those. And then now coming around full circle, which evaluation finding indicates that our interventions for this patient were effective? What do you guys think? Yeah, that one's gonna be C, that they're avoiding an adequate amount, and it looks good if they're not having retention. watery stools all day, they are feeling weak. So we collect that data, it's been going on the last 24 hours. Specifically, they had leftover seafood a couple nights ago. Since then, they have 6 loose bowel movements, mild abdominal cramping. They're very tired. They've got some tenderness, but they do have active bowel sounds. Mucous membranes are dry. Skin turgor is slightly decreased, or they have like a slow rebound. Some vitals there, blood pressure is a little low, they're a little bit tachycardic, got a little bit of a temperature, and they're having the decreased urine output. So we identify acute diarrhea and then possible mild dehydration related to that. Okay, so diarrhea causes excessive fluid and electrolyte loss because of the frequent loose stools. So we're gonna assess, monitor their hydration status, give some fluid replacement. We're worried about skin integrity because if you keep having loose liquid stools and it sits on the skin for any amount of time, even just having the liquid stool come out all those times, it's gonna irritate the skin around the rectum, so we worry about skin breakdown now. And we're gonna provide some education. All right, which of the assessment data here indicates that she is developing dehydration? Mary, did you get this one? Yeah, that's gonna be B. Okay, the heart rate of 104, the tachycardia, we said that goes with dehydration. What's the priority nursing diagnosis then? Abby, did you get this one? B, deficient fluid volume, and it's related to the excessive loss. Okay, and then number 3, what interventions would we wanna implement? Grace, did you get this one? A. Yep, that's A, encourage increased oral intake is gonna be the priority implementation. We wanna do that before we would give them an anti-diarrheal because they've already lost the fluid, so we need to replace it. Like, yes, we might give them something to prevent future loose stools, but if we had to choose which one we would do first, they've already lost the fluid, so we wanna supplement them with that fluid. All right, and then 4, we instruct Maria to report which warning sign that indicates a worsening of the condition. And I touched on this earlier today. What did you come up with, Tiara? C. Yeah, that's gonna be C if there's any blood or mucus, because now with that irritation and inflammation, that's how it can progress. All right, and then the dietary teaching specific to this patient. Amy, what did you get?
C.
Yeah, eat a small, bland diet. So that's known as the brat diet: bananas, rice, applesauce, and toast. So things that are easily digestible, they're soft and sensitive to the stomach, and they provide like quick, simple carbohydrates for the body. All right, and then the last one, what's an important skin intervention for the patient? Nicole, what'd you get? A. Yeah, that's gonna be A, using that barrier cream to prevent any future breakdown.
If there's even, would you give us stuff?
from our vascular system. So our vascular system feeds into our kidneys. Our kidneys decide, what am I gonna return back to the vascular system? And what am I gonna keep and move on through the GU system? So it goes from the kidneys to the ureters. So each kidney has a ureter, which connects it to the bladder. And then from the bladder, the urethra is how urine leaves the body. Okay, liver is involved with nutrition and helping us process and break down our foods. Your food doesn't go through the liver, it goes to the esophagus, stomach, small intestine, large intestine, and then out of the body. But the liver, the pancreas, the gallbladder are what's known as accessory organs, and they secrete hormones and different digestive enzymes, bile, and things like that to help us process and digest our food.
I'm very excited about that.
So anticoagulants are our blood thinners, right? Anticoagulant, coagulation is clot, so anticoagulant is a blood thinner. So if they're on Coumadin, heparin, Lovenox, Plavix, all of those, we would say that they're on bleeding precautions, and one of those is that we assess for signs and symptoms of abnormal bleeding, like bleeding gums or petechiae, or changes in the color of our urine. So that would be pink. Or red if it's really bad. Good, so if our patient is diabetic, they're not able to handle their glucose appropriately, so they could have glucose in their urine. UTI would be white blood cells, bleeding would be our red blood cells, and then pregnancy, we're looking at protein. Sometimes people can develop diabetes just when they're pregnant, but that's a whole story for another day. Anybody got to assess a fistula in clinical yet? Okay, so we talked about this with head to toe assessment, and then it was in your reading and your PowerPoint notes again. So if they have a fistula, that's their lifeline. So 3 times a week they'll go to dialysis, and the dialysis nurse will insert the needles into that fistula and pull all their blood out, replace all their blood, because their kidneys don't work. So dialysis takes the place of their kidneys. So our job though is to assess it, and we assess for the thrill and the bruit. So the bruit is when we auscultate with our stethoscope and we hear the whooshing sounds. Remember I said think of a roller coaster, so you feel the thrill, that's when you palpate and feel the thrill. Okay, so you again should feel a pulse over that fistula site. Yeah, the large intestine, also known as the colon, okay, that's where stool elimination or stool formation occurs. So up until that point, the stool is still very liquidy. The large intestine, as it goes through the large intestine, water is reabsorbed back into the body, and then it's eliminated as stool. Okay, so stomach is where the mechanical digestion or the breakdown continues. There's some acid in the stomach that helps break down the food. Then it goes into the small intestine, where just like with medications, that's where most of the nutrients are then absorbed through all the little capillaries that feed into the small intestine, pulls all the nutrients into the vascular system. And then as it moves into the large intestine, for the most part, everything is absorbed. There's some other little extra activities that happen in there, but the main one is that water is reabsorbed back into the system. Okay, and then the pancreas, like I said, is an accessory organ. Okay, the pancreas is what secretes the insulin to help bring the sugar where it needs to go. Okay, good. So this is one of your drug sheet ones today. So Docustat or Tolase is when you want to do a drug sheet on. We'll talk like tomorrow. We talked about it a little bit here and there. Okay, that's in chapter 27. Just like your zone frame or on Dancitron from last week, it's in chapter 27. Okay, so we go through seven colace, review risk for constipation. It's a stool softener. It's usually every day or even twice a day to help make use of the water that they're drinking and the things that they're eating, and to help that stool be easier to pass. Okay, good. Yeah, we don't want to limit fluid intake to reduce urine production. That's just how the body works, right? So we wouldn't ever tell our little old lady, just don't drink because I don't want to take you to the bathroom. Okay, so we wouldn't do that. Encourage the use of adult briefs at all times. I mean, if we have to, but we want to use all the other things first. We don't want to sit in a brief that's so like, if we have to, yes, but there's other things we'll do first, like a toileting program. Okay, so get them up, take them to the bathroom. You know, you don't have to ask, do you need to go to the bathroom? You know that that's part of day-to-day function. We know we need to eat and drink. We know we need to go to the bathroom. So using our nursing break, getting them up, or delegating that to a nursing assistant so they can get up to the toilet. Okay, and then administering diuretics in the evening. Really, we would need much more information, but diuretics are given in the morning, right? Not in the evening. Because then they'd be up all night. Alright, perfect, wonderful. Okay, so taking frequent tub baths, like I said, because they're just sitting there in their waist, so especially for a female, the urethra is very short, so that would be a risk there.
It's wrong.
Oh no, everybody can try. Yeah, it's wrong, sorry. It is this one, it is the yellow one. Yeah. So all the rest of them are parts of teaching, right? Those are all things that we would educate them on. You guys were all right, except for one person, right? So drink plenty of fluid, wear loose-fitting cotton underwear, urinate shortly after sexual intercourse. All those are appropriate interventions and education. You guys were all right, though. The frequent tub bath and the tight nylon underwear would increase their risk. You don't need to hear me yet? Alright, and then this is gonna be your other drug sheet. It's also in chapter 27. Okay, even if you didn't know it, by process of elimination, enemas, you know, Fezacodal or Dupalax, you've read about a little bit. Okay, so loperamide. So all the other ones are gonna help with constipation. Okay, this one, loperamide or Imodium, it's a teeny tiny little pill, and it's an anti-diarrhea. Okay, so that'll be your other drug. You guys all got it?
What chapter is that?
26. Now, the Bristol was that picture of poop, right, in its various forms, from really loose to very constipated. And then right in the middle, the 3 or 4 was the normal soft form. Okay, so it should be a 3 or 4. patients with ostomies. So if you think of the small intestine, there's the duodenum, the jejunum, and then the ileum. And to help you remember the order of that, there's an acronym that I like to use. It's DJ-IL. Think of like a super cool DJ, right? His name is DJ-IL. That'll help you remember the order. Okay, so the duodenum's first, then the jejunum, and then the ileum. So all the rest of these are different parts of the colon, which is the large intestine. Okay, so the further along the tract that the stool gets, the more solid it is. So how they determine where to make the ileostomy is, or the ostomy, is how much bowel they need to remove, right? So if the whole colon is messed up from diverticulitis or cancer or who knows what, they have to remove all the colon, so it's gonna be an ileostomy, so it's gonna be very, very liquid. Okay, if you get all the way down to like a descending or a sigmoid colostomy, it could be pretty solid stool because there's only a little bit that's removed. The stool has had enough time to have that water reabsorbed, so it would be more solid. So urine culture. A urine culture is a sterile sample. It's a sterile specimen. So we would not like take apart the tubing. We wouldn't empty the Foley bag because that Foley bag, once it's emptied once, now it's no longer sterile. It's contaminated. Okay, so you wouldn't just be getting whatever is growing in the urine. You'd be getting whatever is growing from that Foley bag, from that drainage bag. Okay, so as you start to work with the Foleys, you'll see, so we insert the Foley, it's connected to the tubing and then the drainage bag. Way up here, there's a little port, a little like lure lock, just like our IV stuff, where you just push a syringe with no needle or anything, you just push and twist, and then you can access it. Okay, so if your patient already has a Foley catheter, AKA an indwelling catheter, then we would just go in maybe 20 minutes before we're gonna collect our sample. We would kink that tubing up on itself with like a rubber band so that it doesn't all drain down into the bag, that we have some up in the tubing still. Then we'd go back, we'd clean that port with alcohol, we'd hook up our syringe and withdraw that sterile sample of urine. That's our sample that we send to the lab. Then we just have to remember to unkink it or we're gonna cause retention and pain and all of that. And then that's how we get the sterile sample. So in the PowerPoint, I had some links. If you downloaded it, you could follow those links and then see some of these procedures. So like I had a video of the cystoscopy, which is just direct visualization. So with the cystoscopy, they can do it in the patient's room or they can do it in a surgery room. But the urologist will come in and they'll insert a catheter into the patient's urethra with a camera. So at the same time that they insert that camera, there's IV fluids hooked to it, so it's continually flushing the bladder, and they're visualizing. So oscopy or scope is always direct visualization, and then cysto is bladder. Okay, so IVP or intravenous pyelogram is an image of the kidneys. Pyelo is kidneys, gram is a recording or a picture, and it's IV because they insert that contrast dye. The dye goes through the kidneys, and then they can see if there's any stones, tumors, narrowing or restrictions or anything